I'm going to restart it. Okay, I'm going to start the timer and then start.
Okay.
Okay, so should I say, like, I'm going to be like moderator, my name is Lindsay? Okay.
Yeah.
So for moderator, we have Lindsay. For the pro side, we have Danielle as our stater, Liz Graham as our prover, and Ashley as our attacker. For the con side, we have Ashley as our stater, Lindsay as our prover, and Lauren as our attacker. Some operational definitions of different types of restraint is a physical restraint is any instance in which an individual has to physically hold another individual in order to help protect them from self-injurious behavior, severe property destruction, or physical aggression. Physical restraints are intended to restrict the movement of another individual. An example of this would be a child is engaging in severe physical aggression and self-injurious behavior. His BSP says when doing this, he must be put into a two-person safety hold. Two staff members put him in a hold and restricts his ability to engage in physical aggression and self-injurious behavior. A non-example is a child asks to be picked up and spun around. An adult picks him up and spins him. During this time, the child's movement is restricted. A mechanical restraint is defined as any item or device added contingently in order to restrict the movement of an individual. This can include helmets, posy mitts, black belts, or straight jackets.
I hear a lot of feedback. Okay, go ahead.
An example of this is an individual is clawing at their skin and cannot be stopped. Staff members put a straitjacket on him in order to help protect him from damaging his skin further. A non-example would be an individual wears a standard car seat belt, which they can unfasten. A chemical restraint is defined as any instance in which psychotropic medication administered as needed is used in order to control or rapidly de-accelerate risky behavior. Oftentimes, this is a sedative such as Ativan, can be tablet, sublingual, or IM. An individual is engaging in severe SIB and is screaming, staff administer a PRN medication and this assists to help calm him down. Then he sleeps for a few hours. A non-example is an individual has been diagnosed with ADHD and receives his daily dose of medicine for the day. Seclusion is defined as any instance in which an individual is intentionally isolated from other individuals. Typically for safety or psychiatric reasons, it's not function-based. An example of this is a child is engaging in an extreme behavior and is throwing tables, chairs, etc. at other people. The child is placed in seclusion in order to protect themselves and others from harm. A non-example is a child is trying to take a nap and is isolated from other individuals in order to help them sleep. Timeout is a structured, function-based, and programmatical approach, which an individual is timed out from receiving ongoing reinforcement. An example of this is procedural exclusion or confinement timeout. When the timeout is complete, he or she is timed back into reinforcement.
All right. So I'm going to talk about appropriate use of restraints. Restraints should only be used in a crisis or emergency situation. Although they are aversive, they are not to be used as punishment or coercion. They must be deemed clinically necessary in cases such as self-injury, aggression, sometimes property destruction if it is severe, like a piece of furniture is being thrown, but not if like paper is being torn. So it needs to be based on a treatment plan and it needs to be based on level of severity, as does the self-injury and the aggression. Immobilizing an individual's arms can be helpful for reducing self-injury. Additionally, using FCT training along with a brief restraint can help. Sorry, I lost my place. FCT training along with a brief restraint can help train that individual to ask for what they need or explain why they're upset in that moment, and not feel like they always have to go into a restraint in order to get whatever that need is met. Restraint can extinguish access to other reinforcers such as weapons, if the individual is trying to get a pair of scissors or something else sharp, or like I said, property destruction before, if they're throwing furniture, it decreases the access to those dangerous items. Lastly, the restraint can provide alternative forms of attention other than verbal and only when appropriate. So averting your eye contact with an individual if you are doing physical management, not talking to them unless you're doing compliance checks or they're stating something that they want appropriately. Again, restraints are meant to be and are hopefully aversive to the individual, and if physical restraints are somehow reinforcing to the individual, they should not be used on that particular person. That's all I got. I don't have a really good closing statement for that, so.
Okay. So that's me. The management of aggressive injuries and/or destructive individuals with autism and other developmental disabilities can pose a significant challenge to the staff working with them. So because of this, it's become commonplace for restraint and seclusion to be used. However, restraints and seclusions of all forms are often viewed as negative experiences that have no supporting evidence of effectiveness. By using these methods, it can be viewed as ethically unacceptable and an infringement on the autonomy and dignity of the individual. Some ethical concerns that are debated about the use of restraints and seclusion on individuals with autism and other developmental disabilities include the potential for death or injury. According to the BACB Ethical Code 6.01, behavior analysts must always uphold and advance the values, ethics, and principles of the profession, which includes the core principles of doing no harm. So the use of techniques that put individuals at a risk to be injured or die is considered unethical by many who believe they should be discontinued. Even if no physical injury results from the restraint or seclusion, there may also be psychological injuries to which the nature, extent, and duration is hard, if not impossible, to measure at times. So it makes you think, is it ethical for educators and others who work with children to use any procedure that has demonstrated the potential for death or injury? Another issue is the failure to use the least intrusive intervention. Ethical Code 4.09 states that behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures to be likely effective. At times, however, the policies and procedures associated with the use of restraint and seclusion can be violated, misapplied, or abused, and may result from a failure to use early effective interventions at the first sign of inappropriate behaviors. They may be implemented at times they're not warranted, because typically restraint and seclusion is designed to be used when an individual is in crises, which is defined as continuous aggression, self-injurious behavior, high magnitude destructive behavior. There are many instances, however, that these procedures are used before it actually reaches a crisis situation. Another issue is the inappropriate restrictions on the liberty and removal from access to education. Education is the basic right of children, according to the Individuals with Disability Education Acts. So a related human civil rights issue is the fact that restraints and seclusion may result in a student being removed from the educational environment for a significant amount of times. This is a serious concern because, especially for students with special needs who are typically already performing below grade level academically. So the time away could just contribute to these deficits. The repeated use of a potentially dangerous and ineffective intervention. The Code 2.09 states that clients have the right to effective treatment that has been validated as having both long-term and short-term benefits. So the ongoing use of a behavior reductive intervention that is not producing significant changes should be viewed as an indicator that the intervention is not working, and it should be used no longer than needed. Additionally, the high rates of restraints that are being used can be viewed as evidence of treatment failure. Additionally, there is also a disproportionate use of certain critical groups. Recent data has demonstrated the disproportionate use of restraint seclusion with students who belong to certain minority groups or those who are disabled. Mechanical restraints were also used disproportionately, applied to minority students and students with disabilities. An additional issue is the insufficient professional training, supervision, and monitoring. All behavior analysts are supposed to be, they are not supposed to practice outside their boundaries of competence. So, and it has become widely acknowledged that more students with mental, emotional, behavioral disorders than ever are being served in public schools. And unfortunately, the teachers are not educated how to effectively interact with some of these kids. So because of that, they're put in situations that may not be the best for them, which just acts as antecedent conditions for the challenging behaviors to come out. So a final thought, more or less, is safety has to be a driving concern. So is it ethical to use a potentially risky practice simply because we do not yet have a better solution?
So we previously heard the ethical concerns with restraint and seclusion, and that there is a potential for injury or death with the use of these measures. We assert, however, that the overall potential for injury or death will be low if restraint or seclusion is used least intrusively, when appropriate, and according to our federal or state policies, procedures. So for example, the ABAI, they have their position paper on the use of restraint and only used when necessary or applicable. Of course, all their state and provincial affiliated organizations follow that same approach. Does what's up?
This is my slide.
Oh, I'm so sorry. I just started talking.
That's okay.
Oh my God.
I'm sorry.
No. Okay, abort. Okay, well, good thing this is a test run.
Yeah. Did something go out of order or?
No. I was reading my notes. I just. Okay.
Okay. Sorry, I'm pulling up my notes. Okay. So the first issue is failure to use least intrusive intervention. We should be trying.
Lindsay, I think Liz was supposed to go because Liz, you're the con prover, right? Or the pro prover? I know you're the opposite of me, so I'm pretty sure yours came after because me and Lindsay are on the same side.
Can you pause the timer really quick, Lindsay?
Yeah, I just did.
Okay.
So I'm the pro evidence, aren't I?
Go back to the meet the debater side, because that'll say who. Like, if you go based off of that, it should have went Danielle on one side, then me.
Yeah.
Yeah. So then Liz should have been going.
Okay. Well, we need to get these slides like.
Yeah. The slides are out of order, but Liz should have been the one that was talking at that point.
Okay.
I thought I was following the chart, but then I didn't know because I didn't want to change the slides.
Is this yours, Liz?
No, that one's mine. So that one should be after yours, Lindsay.
That one's mine.
Okay.
That's mine.
Okay.
Okay, so are we sure then? Because I just had the notes from our talks.
I can pull up the outline one more time just to make sure.
I have
the
the
story.
outline up right now. It's
Okay.
pro stater makes her points, con stater defines her counterpoints, pro prover begins her evidence. So is that you, Liz? Pro prover?
Yeah.
Okay. Then con prover delivers their data. Pro attacker moves in. Here, let's do this.
Okay, so should we fix the PowerPoint quick, or?
Yeah, we should probably move those slides around.
Yeah.
All you have to do is just pick up and slide them. It shouldn't be hard.
Yeah.
Once you get the Google Slide Maker.
Slide is next after Liz.
I put in that table, but I don't know if we need it. I'll just erase it because it's going to be confusing, right?
I can move it.
Well, what if I just erase it? Because it's just going to confuse our flow.
Okay.
Really need to reference it.
Fine.
That works.
Okay. Do we think we're good, or?
Yeah, I think so.
Okay. So do we want to start the timer again, and I'll just start blabbing again?
Yeah, whenever you want.
Okay, well, I'm ready.
Okay.
Okay, so we previously heard the ethical concerns with restraint and seclusion, that there's obviously a potential for injury or death with the use of these measures. So we say that the overall potential for injury or death would be low if restraint or seclusion is used least intrusively, when appropriate, and according to federal or state policies and procedures. So, for example, the ABAI provides their position paper on the use of restraint, and it's only when necessary and applicable. And their state-affiliated organizations follow that same approach, as does the U.S. Department of Education. So there's also behavior management curriculums that are really great, such as PCM or QBS's safety care. And these are developed from the evidence-based practice, and they're created by BCBAs. So they obviously use ABA principles, least intrusive approaches, and are reinforcement-based. So obviously PCM and safety care's use of physical intrusive approaches is only used in cases of imminent risk. So in reality, injury or death can occur at any time when supporting these individuals with challenging behavior, but direct care staff who are properly trained and can appropriately use these restrictive measures, and when required, will decrease that overall risk. Next, we do agree on our side that there should be evidence of least intrusive interventions as per the Compliance Code 4.08. So before implementing any punishment-based procedure, we know that behavior analysts should ensure that appropriate steps are taken to implement reinforcement-based procedures first. But that's unless the severity or dangerousness of the behavior requires immediate use of some more aversive procedures, and that's just because there's immediate risk of harm or fatality. So there's also consequences associated with delayed intervention in Van Houten et al.'s 1988 paper, but a competent behavior analyst can assess that risk, and they can determine if taking the time to implement other strategies that are more positive-based versus acting immediately would be more ethical and on a case-by-case basis. Our next thought is that going back to the original pro statement, exposure of an individual to restricted procedures, we agree, is unacceptable. However, again, unless it can be shown that such procedures are necessary to produce safe and clinically significant behavior change. So if an individual is placing themselves or others at risk, we may need to use those restrictive measures, and they might be warranted for the severe behavior because, as per the BCBA Code 2.09, all clients have the right to effective treatment. And yeah, least intrusive historic interventions may not have worked in the past. So these cases would require approval and only be used during crisis or emergency interventions and only when clinically necessary to keep all safe. So Van Houten's paper in 1998 did talk about the combination of punitive and positive-based strategies. And according to that research and current research, it's still the most effective treatment for individuals who show severe and dangerous behavior. So we've been warned against restrictions on liberty and access to education or therapeutic environments. Again, our Compliance Code 2.09a states that all clients have a right to effective treatment, and that might include restraint or seclusion if warranted for therapeutic or safety purposes. So some examples there, we have to uphold ethical conduct, such as respecting the autonomy and independence of our clients. There might be time where improved functioning of an individual may require the reduction of certain behaviors that can be dangerous, but they also serve as barriers to their independence. So using brief physical restraint, like response blocking, maybe some mechanical restraints, or brief use of timeout can allow for a student or individual to remain socially included and in the setting that they're in, not have to take them out, and just with those brief uses of intrusives when required. So again, ongoing learning can occur and minor disruptions to others. To meet an individual's socially meaningful goals, it might be necessary also to expose the individual to temporary discomfort or a little bit of risk. We're reminded, evidence states, and that could include use of a combination of intrusive measures. So an ineffective treatment or doing nothing would be more so unethical. So we heard about the concern of repeated use of a potentially dangerous or ineffective intervention. And this shouldn't even be encountered by any ethical BCBAs if we all follow the compliance code. As a competent behavior analyst, we always ensure that aversive procedures are accompanied by an increased level of training, supervision, oversight, and then our federal regs and the ABAI's position on the use of restraint exclusion again reminds us that the use of any restrictive interventions, we need to have mandatory staff training, there's competency and mastery-based techniques, there's ongoing monitoring and supervision involved. So that should be happening. We should avoid that potentially dangerous and ineffective interventions. Just rounding up, there is a disproportionate use with certain critical groups, so restraint and seclusion. We admit that. The current literature indeed indicates that complex and challenging behavior is more likely with individuals with autism and intellectual and developmental disabilities, especially when they have lower cognitive functioning or complex behaviors. So again, a higher prevalence of restraint and seclusion is in this population. But current literature also talks about and indicates that when restrictive procedures are used properly and effectively using an evidence-based approach, therapeutically or programmatically, so pre-planned, there is dramatic decreases in challenging behavior and socially significant behavior change. And then just lastly, the ethics involved. So good news, there are federal policies and procedures to follow, and there's always an objective criteria for use of restraint and seclusion, which is the imminent risk of harm.
I thought I had this all like together, but I'm gonna have to move like my slide up. Okay, so the failure to use least intrusive intervention, we should be trying to find alternatives rather than using restrictive procedures. Some alternatives could be crisis de-escalation training. This would help train individuals to use alternative strategies rather than using restraint and seclusion. It would teach individuals to use the least amount of physical management possible for the situation. Training for managing agitated patients. This training would be focused on how to better handle patients who are escalated. The particular clinic that this program happened at, they created a completely new role for their staff, and it included more extensive training on how to handle individuals that are in a crisis and how to better de-escalate that crisis. The potential for death or injury. So at JCPS in Kentucky, a 16-year-old boy with autism was put into a restraint, and as a result, he suffered 2 fractured femur bones. He had to spend time in the ICU, and he required a blood transfusion. The news article also reports that the extent of these injuries could have led to a fatality, and this just goes to show us that injuries or death could happen quickly due to inappropriate restraints. And it's also an example of how quickly restraints can go wrong and how it can be easy for some people to use too much force when initiating the restraint. Inappropriate restrictions on liberty and removal from access to education. If we are constantly removing children from classrooms or wherever they may be, whenever they're being disruptive or engaging in behaviors, not only are we taking them away from an educational setting, but we may very well be reinforcing their behavior. We should be trying to find the function of the behavior and trying to come up with behavior plans to help them be able to stay in the classroom and reinforcing their appropriate behaviors instead. Dangerous and ineffective intervention. Studies have reported negative findings from students being placed in restraints and seclusion, and this includes injuries to staff as well as patients and potential death. It could also cause further aggression, which we see in studies, and it has the potential to cause PTSD. So some ethical issues. We shouldn't have interventions in place that can make children have more aggression than what they had before. And we should always be trying to find the least restrictive physical management procedure possible. And we should try to find alternatives and learn more about how to handle patients who are escalated or engaging in behaviors such as physical aggression and self-injurious behavior. We should also try to de-escalate individuals before they get to engaging in behaviors such as physical aggression and self-injurious behavior.
So first off, there are professional guidelines in place for restraint and seclusion. The BACB ethical code states that behavior analysts maintain knowledge of current scientific and professional information in their areas of practice and undertake ongoing efforts to maintain competence by obtaining and maintaining appropriate professional credentials, by attending appropriate trainings, conventions, conferences, etc. So agencies provide crisis resolution and de-escalation training for staff that includes techniques for the safe employment of physical interventions. A lot of them no longer include certain prone restraints because of the fact that those have been found to be dangerous. In addition, for safer versions of physical restraints, organizations have also called for improving safety monitoring during restraints, such as having all appropriate educators trained in CPR, ensuring the availability of a portable automatic electronic defibrillator, and other relatively easy to use methods are also available for monitoring signs of physiological danger. Things that are always considered before seclusion and restraint is the degree of unmanageability and the degree of danger. People that are put into restraint, these ones it's done in crisis situations. This is when an individual has been continuously self-injurious, continuously aggressive, or the behavior is in high magnitude and destructive enough that it is possibly going to be harmful to themselves or others. So some commonly cited reasons for the use of restraints and seclusions is to prevent a child who's acting out from controlling himself from harming himself and others. When individuals have violent outbursts and others in the vicinity, sometimes it can be dangerous for anyone, even if they weren't involved directly in the situation. So if there's only a few people in the area, it may be easier to clear out the area. But if the individual is in a larger group, it may be easier and safer to everyone to remove the one individual who's having an outburst. And if the individual is truly in crisis, it's probably going to need to be a physical transportation procedure that is used. These procedures are also used to help prevent the individual who is engaging in property damage. It contains the destructive behavior and provides an external safety control for the child who's internally being overwhelmed at that point in time. When they engage in these property destruction, it's not just protect the items that are being destructed. In the process, the child or individual themselves may get hurt. So it may be necessary to employ the transportation procedures to a designated safe room to ensure that the individual does not cause harm to themselves in the process. It also helps bring sense of control to a unit. Aggressive children with others in the vicinities, it can cause a group contagion. So by removing them, it helps keep the problem from increasing. And also avoids rewarding and thus reinforcing the violent and destructive behavior. It can be used as a response to rule violation, other acts of compliance where other less restrictive methods have been used. According to 4.09, least restrictive methods must be used, but it does leave the behavior analyst the one to determine what procedure is most likely to be effective. So if they feel that they have to slowly increase the physical restraints, then that is what their job is to do. They do have that right to do it. Crisis management procedures entails that the level of restriction increases if persistence increases, but as resistance decreases from the individual, their level of restriction also decreases as well. This is why we're always giving feedback. It can promote self-control and enhance coping skills by being an interactive process in which the care worker listens and responds to the child. And because the restraints encourage the child to verbalize their strong feelings rather than act them out, which will help promote coping skills and internal means of self-control through the verbalization of difficult feelings. It can be viewed as therapeutic intervention to modify the inappropriate behavior of people, such as pica. It can also be used for custodial purposes, for example, as if to capture a young offender who's attempting to escape. It also is used in times to decrease sensory input. A lot of the people that we work with have either a heightened sensory input or so if they're overwhelmed with stimuli, they might not be able to process anymore and may need to be removed and put into a secluded room to help them slowly calm down. According to Ethical Code 4.07, it says the environmental conditions prevent the implementation of behavior change program, then we must seek to eliminate the obstacles that are responsible. So if a person is overstimulated due to the environment, then at times we do have to remove them from the environment. Your turn, Lauren.
I am here to counter the arguments heard for the use of restraint and seclusion. So one of the arguments stated was that restraint and seclusion is used only as a crisis or emergency intervention. However, according to research by Sherman, Peterson, Ryan, and Billingsley, there's actually insufficient professional training and monitoring regarding restraint and seclusion. Therefore, are the individuals trained to know when an individual is in crisis situation? And this relates to the BACB code 1.03 that talks about making sure we're maintaining competence through professional development. There needs to be more training and research on interventions to use restraint and seclusion. And there's also currently no studies that show safety monitoring of restraint techniques. Another argument was that immobilization is an effective intervention for reducing challenging behaviors such as SIBs. And I want to argue that our less intrusive interventions being used before this immobilization, which refers to the BACB code 4.09, these restraint and seclusion interventions may be used as a quick ending to the behavior by professionals, and they may not be implementing antecedent de-escalation and preventive strategies first before going in with a hold. And another important factor is restraint and seclusion appropriate when there is a risk of death? These methods are found to be potentially dangerous and ineffective. And as a BCBA, we have the obligation to do no harm to our clients. And this may not be the factor if we are providing restraint and seclusion techniques without training. If restraint and seclusion are being repeatedly used with clients, that also means that they're ineffective. One of the literature reviews that was cited by Fisher in 1994 that was discussed for the use of restraint and seclusion, they actually concluded their review by stating that seclusion and restraint are basically effective in preventing injury and producing agitation. So first, when I read that, basically is very subjective to a reader. And second, a study showed that there was an estimated 8 to 10 children in the US that die each year due to restraint, and numerous others suffer injuries. Another main point that was argued was that we need to be teaching replacement behaviors, such as functional communication, in conjunction with the use of restraints. We can all agree that we should be teaching replacement behaviors, such as functional communication. However, restraining or secluding the child is actually taking away the right to education, because they are removing them from an environment where they can possibly be learning these skills that they have deficits in that may be leading to the challenging behaviors. And this refers to the BACB code 2.05 that talks about the rights of our clients. Our clients have the right to education, and for us to teach them these skills to replace these challenging behaviors. It's also argued that restraint extinguishes access to other reinforcement and is meant to be aversive. However, if it's not aversive or it's not removing them from reinforcement, it can actually be serving as reinforcement by giving the individual attention or allowing them to escape from a difficult demand. With insufficient training being given on restraint and seclusion, it questions whether there's FAs being conducted or FBAs to actually determine the function before using these interventions for crisis. In conclusion, I think that there are many cons to using restraint and seclusion, most stemming from insufficient training and monitoring, and there needs to be more universal policies, training, and research on the use of restraint and seclusions before they're being implemented.
Okay, so the first field question is
training. Hold on, because on the outline it says that the pro stater and the con stater each sum up what our arguments are salvageable. So were we doing that before or after the field questions?
Oh, my bad. I didn't realize that. It don't matter to me. We are at like 35 minutes.
Okay, so we have like 10 minutes to play with. What do you guys think? Just because it is on the outline that we are supposed to sum up like each side's points.
Yeah. I'm okay if you guys go ahead and do it like before this.
Okay, great.
I think we can just do like one or two sentences, nothing long, just so we have it in there.
Okay. So in conclusion, for the pro side of use of restraints and seclusion, in certain cases, these procedures are inherently risky, and they have in the past resulted in death, unfortunately. This is why staff training across the board is so important for anybody who's going to be working with this population, and anybody especially who's going to be working in an environment where there is a certain level of aggression from the clients that we serve that give us no other alternatives or very little other alternatives besides physical management. Liz had mentioned earlier that there are procedures such as PCM and QBS, which are based off of least restrictive to most restrictive procedures. So in short, on the pro side, sometimes physical management and seclusion is unavoidable in certain cases, but it is important that the staff members who are doing these types of restraints are not only trained to the best knowledge possible of what the treatment plan is for that particular client, but also have vast knowledge of when and when not to implement these procedures that they are taught.
Or the con side. Sorry, I don't really have too much put together for this. I'll have to come up with it because I didn't realize.
I think like literally a sentence is fine.
Yeah, exactly. Pretty much the key argument in favor for restraint and seclusion is the fact that the techniques are needed to ensure a safe environment. And perhaps technology has not evolved to the fact to meet that need. But at the same time, we still have to consider the fact that these are children or individuals, adults, these are humans that we're using. So is it ethical to use a potentially risky practice simply because we don't have a better solution? How many instances of restraint and seclusion should trigger a review of potential violations of these people? Like, how many times does it have to before it's considered ineffective? How many people need to be injured before it's considered that? So is it ethical to practice this when there isn't actual evidence-based, or there isn't evidence proving the fact that this is effective?
Okay, are we ready for field questions?
Yeah.
Okay, so the first question is, training can be a potential issue for those who perform restraints. Are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints?
So according to Sherman, Peterson, Ryan, and Billingsley, insufficient training in crisis management may be rooted back to the lack of effective intervention training. So staff may have a training on a crisis intervention strategy provided by this clinic or setting where they work, but that does not mean that they have the ability to de-escalate a situation or apply antecedent interventions. They also go to state that there needs to be more training than just simply crisis management. To improve training, there should be an overall comprehensive training that involves obtaining experience with challenging behaviors, having the ability to engage in quick decision making, and training on a variety of preventative strategies rather than just a simple crisis intervention strategy.
And Compliance Code 4.08 does tell us that behavior analysts must ensure that any aversive procedures are accompanied by training. And then, of course, Code 5.0b states that if the supervisee or the direct care staff don't have those skills, the behavior analyst must provide that training. So some ways to do that, like we just mentioned, sufficient training would be performance-based curriculums, because there's a lecture component, the trainer models the skills, there's mastery criteria, and competency. So with that errorless learning, the verbal feedback, and the role plays, research does suggest that this is the most effective way to acquire skills, to generalize skills, and maintain the skills. It's an evidence-based practice.
Okay, we're down to 5 minutes. Question 2 is, the use of restraints and seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it is not something that can be used across various settings? What happens if a child has a mechanical restraint in one setting but then moves to a new setting where that type of restraint is not allowed?
So I think that it is the responsibility of the previous facility or placement of that child, if they're going into an adult service, if they're aging out, or if they're just being transferred to a different facility. That facility that they're being transferred from needs to be responsible for seeing what type of physical management procedures, including mechanical restraints, are in place for that individual. And if they need to go into a placement where a familiar type of restraint is necessary but not available, it's the job of that facility and that staff to start to wean off of that, of mechanical restraints, for example, and work into like a physical management type of restraint. Otherwise, they need to find an appropriate placement where mechanical restraints are allowed if that is absolutely necessary for that individual. And that might be psychiatric placement rather than a general population for adult services, for example.
Okay. The last question is, do you have any personal experience related to this topic that you would like to share?
I worked in a facility where we dealt with a high level of aggression. I worked there for 4 years, and I also taught safety care for 2 years. Anybody else?
I worked in a few settings, and I was trained on different techniques in each setting. And in one setting, I was trained in PCMI, which is a 22-hour training, very comprehensive. They teach you antecedent and de-escalation strategies. And in another setting, I was taught CPI, and it was a 3-hour workshop, and that was it. And I think that that just goes to show that there's inconsistent training across settings and across states that may be leading to some of the flaws found in restraint and seclusion.
So in my current role, I actually have to use professional judgment pretty much every day because I'm responsible for assessing and creating plans with intrusives, perhaps, for individuals who are adult and have challenging behaviors. They're coming out of forensic or treatment facilities. And then, yeah, we just have to look at the risks and benefits for that. So, yeah, I'm pretty familiar with this too. I think we all have some experience.
Okay. Do we want to go on to the next slide?
Is there another?
I think we're done, right?
Yeah, I just meant
Yep, we're good.
Okay. We are at 43 minutes.
Cool. Do we